Okay, so we'll be discussing disease surveillance and notification, otherwise called integrated disease surveillance and notification systems. Okay, so yeah, that's our topic. Confirm that you can see my slides clearly.
Yes, ma'am.
All right. So we'll look at the background. We'll look at the goals of the IDSR program. We'll look at the functions. We'll look at the priority diseases, the reporting structure, and tools over the next couple of minutes. So, what is integrated disease surveillance and response? Before we talk about IDSR, let's talk about surveillance. The concept of disease surveillance refers to a continuous watchfulness over the distribution and trends of diseases. Trends just talks about the pattern of disease over time, how diseases occur, in whom they occur, when they occur, over a time period. So when you talking about trends, you're always looking at it over a time period. So over a period of time, how does this disease manifest? How many people are affected? What time of the year, of the period under surveillance, does this disease is this disease more prevalent, and so on and so forth. So surveillance really talks about a continuous watchfulness. So continuous watchfulness means that you're collecting data and information about a particular disease all the time. So there needs to be a system in place for the systematic collection, analysis, interpretation, and dissemination of health data. So the disease surveillance system entails that you will put something in place where information, data can be collected every single day if possible. You have a very regular way of feeding the system with a particular information about the disease, the characteristics of the disease that you are interested in keeping a watchful scrutiny over. And so all this information that you're collecting is not just for the sake of collecting it. The information generated is used for public health action. If by collecting information over a period of time, we can tell a lot about how that disease is occurring, we can tell whether the prevalence goes high at a particular point in time or whether it comes down. And if you see that the prevalence really peaks, you have more cases of that particular disease at a particular point in time, and you can see a pattern, then you can actually intervene, and your intervention methods and measures will be more effective if you're armed with enough information about that disease. So that is the whole idea behind the concept of disease surveillance. The reason why we need this type of watchful scrutiny, this type of watchfulness over the occurrence of disease through a systematic method of data collection, analysis, interpretation, and dissemination is that, diseases are a major cause of morbidity and mortality, especially communicable diseases. So disease surveillance really started with communicable diseases because of the issues with the burden of communicable diseases. But it doesn't just end with communicable diseases. Disease surveillance has now extended to non-communicable diseases. Well, most of the principles of disease surveillance that were developed were initially directed to the control of communicable diseases. So we know that diseases are the major cause of morbidity and mortality. Communicable diseases create a lot of concern and issues especially in sub-Saharan Africa. Nigeria is not exempt from this. We know that many of the communicable diseases are preventable. There are interventions that you can put in place to be able to stop these diseases at various levels. If you recall the levels of prevention, there's a lot that can be done at each of those levels to either stop the occurrence of the disease or reduce the occurrence of its morbidity and mortality from this disease. But there are a lot of issues and challenges around social, environmental, and economic determinants that actually affect our ability to be effective in prevention and control. And surveillance really is very helpful as a cost-effective way of getting enough information about a disease to be able to bring up prevention measures. So therefore, it stands to good reason that health authorities would depend on information on the incidence of an infectious disease. If you know that, if you know how often a disease occurs, where it will occur, how it will occur, if you know the pattern, if you know the trend, you're better able to put in measures for prevention and control. So information collected through the disease surveillance system is used to detect outbreaks and prevent further cases of a disease. It's also useful for monitoring the epidemiology of the disease and very, very important for implementation of interventions to protect the health of the public and the health of populations. So surveillance, early detection and notification is very important in the efforts to prevent and control the spread of emerging, re-emerging, and novel infectious disease. An emerging disease, I mean, I'm sure you've heard that before, but an emerging disease is a disease that is coming up for the first time. We hadn't really had much information or knowledge about it. It's just coming to the fore, and seeing a disease that is coming up for the first time, there's a lot of fear, there's a lot of concern. And if you have a surveillance system, in place, you are able to identify what's happening with that disease pretty quickly and bring in prevention measures. A re-emerging disease is a disease that was in existence, has been under control. Since sometimes maybe you even felt that you had controlled or eliminated that disease, and then it comes up again. And the re-emergence of that disease causes concerns. And then, of course, a novel infectious disease, we don't know about it. It has never ever happened. It's new, or it's actually not new, but it is creating a new type of illness and affecting the different set of or category of people than what we've been used to. Surveillance actually helps you get the information and gather the information to be able to do that. So, I mean, that brings us to the importance and use of surveillance information. You're able to detect sudden changes in the occurrence of and distribution of a disease. If you're keeping that regular watchful scrutiny and you're collecting data in a systematic manner and analyzing it and interpreting it, if there is a change in the occurrence of a disease, the incidence of the disease, the prevalence of the disease, and the distribution, who it affects, when, and all of that, all those descriptive epidemiology issues, if there's a change, you're quickly able to identify that change. It also helps you to follow the long-term trends. We call that secular trends in the pattern of a disease. It helps you to say, okay, let's forecast, let's plan for the future. This is the way this disease occurs. So at this particular time, at this particular period in the year, we would give maybe vaccinations. We will give vaccinations to be able to help to forestall, because we've seen year after year that cases of upper respiratory tract infection, probably caused by SARS, the SARS virus, happens during the winter season. So before winter starts, we will give flu shots to everybody as a way of precaution. Or you know that we're going into cholera season, and there's usually during the dry season you get into because water bodies dry up and all of that, people start to patronize sources of water that is not potable. So you know there will likely to be a cholera outbreak at this particular time, as you've seen from year in year out from keeping these records. And so you start to put preventive measures in place: health education, health promotion, information, and so on and so forth, including vaccination. It also helps for planning and resource mobilization. When you know what you're dealing with, because you've kept an eye on it, you know the resources that you need, and you have enough time to plan to be able to bring those resources together. And of course, when you started your control programs, it helps you to monitor your progress. If your control program is working, That means that the incidence, the prevalence, the morbidity, the mortality, the burden of that disease should be coming down. Your surveillance will tell you whether you're having more cases or less cases. It is if you recall, during the COVID pandemic, in the heat of the COVID pandemic, we were having daily updates from the Nigerian Center for Disease Control. And those daily updates were surveillance data. How many people had COVID, were diagnosed with COVID the day before? How many new cases of the disease? How many people have been vaccinated? How many people have died? That's surveillance information at its best. So that was a daily surveillance. Every day, from wherever cases that would come up, everybody would report into a central system. The central system would collate it and then make it public. So that was so when you saw the number of cases starting to come down every day, they are announcing fewer and fewer cases. That told you that there's progress being made in your control program. It's also useful for advocacy to say, look, we know this much about this disease because we've watched it, we've observed it, and we know these are the interventions that work against this disease. So you go and advocacy to either policymakers or to government officials or to people in authority to say, put these things in place so that you can have prevention and protection against disease. And of course, surveillance data gives you a lot of information that is very useful for all kinds of research. Okay, so as beautiful and as wonderful as that sounds, you know that there have been challenges, and there are still challenges with disease surveillance, especially in sub-Saharan Africa. So we're going to look at some of these challenges and try to situate them within our own experience, whether those challenges are run true for us. Oftentimes you have a failure to report. Now, surveillance is almost 100% dependent on reporting and notification. If people who identify a disease that your government is interested in, the system is interested in keeping a close watch over, if they don't report the occurrence or even the suspicion of that disease, you may be deceived into thinking the disease is not occurring until so many people start to get affected, and maybe morbidity and mortality patterns go up very high. You may actually be tempted. So failure to report diseases, especially diseases of epidemic proportion, is one key. And there are so many reasons why people will fail to report. There are deficiencies in the system. They do not have the capacity, the competence to be able to report. They do not have the system. So maybe it's an electronic reporting system now. There is no data. There are a lot of issues with reporting. It may also be for more sinister reasons. People fail to report because they feel that something will happen negatively if they report. Remember, during the COVID era, people were hiding cases of COVID because they were afraid that government will come, carry the person by force and put the person in an isolation center, or government will shut down the business or the hotel where the person has been staying, and so on and so forth. So why report? Why report? There's incomplete and late reporting. So if when people actually do report, when health facilities and systems actually report, sometimes they don't even fill out that tool properly. We'll see the tools that are routinely used for reporting. Sometimes they don't just fill it out, and then sometimes it is very late. You report after the deadline for the last set of reports to come in, and that makes it difficult for anybody to do anything useful with that information. So when the report goes up, what are the challenges that can happen? So oftentimes you have inadequate analysis. So somebody is looking at the report. So the report moves from the health facility for routine surveillance. We'll see it in a couple of slides down the line. The report moves from the health facility to the LGA, and from the LGA to the state, and from the state to the federal. What if at the LGA level, this health facility
information is supposed to be collated. What if at the LGA levels, somebody is is trained enough and committed enough to start to see patterns, to start to see things that are changing and that need that I point out to the fact that intervention is required. But that person, in another scenario, the person who is supposed to look at the data and make those decisions doesn't have what it takes, is not competent to be able to do that. So the analysis is either not done or is inadequate. Okay, move that data to the states coming from all the LGAs, and still there's somebody who doesn't know how to look at that data and report and interpret it. But all they just do is push it forward. They just said we should submit. So you just submit. You don't even look at it. It creates challenges. What about the laboratory? So you remember, you have learned things about case definition. So there's a definition for a suspected case and a confirmed case. Laboratory diagnosis is often critical for you to make a confirmation of the diagnosis. So it moves from a suspected case to a confirmed case very often in the presence of laboratory detection, so laboratory diagnosis. So we have a big challenge with laboratory diagnosis in our country. Very recently, we had a admission into the infectious disease unit, where I work, and we were thinking that this may be Marburg because they were coming from outside of the country, and they had the symptoms which we thought were in keeping with a suspected case of Marburg. So isolated them, which is the thing to do. They were ill, so we started to treat them. We isolated them, took samples for investigation, and there's only 1 or 2 places in the entire country where you could send those samples to, where they could tell you whether this is Marburg or not. So we sent samples for PCR detection for Marburg, and it took maybe almost over a week, well over a week, to get the results back, because very few centers do that. But we're even lucky that we had at least 1 or 2 centers in the country that could tell us whether this was Marburg, and turned out to be negative, thank God. But I mean, what if there was no place where you could diagnose Marburg? You would never know. If these people had Marburg, you would never know. So that's a challenge with laboratory for case detection. Then you have inadequate involvement of the clinicians. So the people working in the healthcare facilities most times are very far removed from the Ministry of Health and the epidemiology systems that are tasked with collecting and interpreting surveillance data. So a pediatrician sees a child in the children emergency ward and it thinks that child may have measles. Treats the child, admits, treats the child, goes home, doesn't report. May not even know is supposed to report. Probably on the radio hears that there's an outbreak of measles. And I mean, maybe does or doesn't say anything about what he or she saw. Or take another scenario where the diagnosis isn't very clear-cut. Not every disease has laboratory diagnosis. And so you depend on the clinicians quite a bit to be able to make diagnosis based on clinical signs and symptoms. And so if you are made the one, maybe as a DSNO, disease surveillance and notification officer, you may not know exactly what you're dealing with if a clinician is not involved giving you that diagnosis. And of course, that feedback to the health workers and to the community is also there, because disease surveillance and notification is not supposed to be a one-way, where the information is gotten from the health facilities to the LGA, from the LGA to the state, from state to federal. It's supposed to be two-way, where feedback comes from the federal to the state, from the state to the local government, from the local government to the health facility to say, look, this is the data you all sent, makes us think that so is happening, and this is what we need to do. So there's really oftentimes health workers collect this information and send and don't hear anything about it. And of course, the other perennial challenges that have to do with staffing issues, logistics issues, and so on and so on and so forth. All right, so I won't bother you with all this historical perspective. I expect you to go back and read it up. But the thing is that at some point, the African region of the World Health Organization decided to adopt an integrated disease surveillance and response strategy for strengthening national disease surveillance. So while surveillance is a concept, there's a strategy for ensuring surveillance in WHO African regions. And that is why it is specifically called the Integrated Disease Surveillance and Response System. So integrated because before then, what you were having is you have surveillance systems for different diseases. So you had a lot of vertical programs. So somebody's interested in maybe Bill and Melinda Gates is interested in neglected tropical disease. They set up a surveillance system where you are reporting about whether you see leprosy or you see any suspected case of elephantiasis or leishmaniasis, and you're reporting. Somebody else is interested in HIV/AIDS and comes and sets up an elaborate system where you are collecting information for HIV/AIDS and you are sending. Somebody else is interested in TB, so you are sending a report for TB differently, sending a report for HIV/AIDS differently, and those vertical systems were causing a lot of chaos in the health system. So we say, okay, why don't we integrate? Why don't we have one reporting tool for epidemic prone and other priority diseases? Let's bring all the diseases that we should be interested in together. Let's have one reporting tool. Let's train the health workers at once. Let's provide the health facilities with what it takes to be able to report. So it is a strategy. The IDSR is a system and is a strategy to be able to achieve disease surveillance. All right. So we brought it in, domesticated it in Nigeria in 2005. All right. So it's important for us to know that the IDSR strategy has been in existence in the country since 2005, and then it was revised. It was revised. The technical guidelines were reviewed and revised in 2008. So what has happened? We've had 3 revisions to the technical. So the technical guidelines are just like a compendium of guidelines about what kind of diseases are we interested in, how often do we get the information, what kind of reporting do we do for these different kinds of diseases, and who gets the report, and what is the system for translating the information and communicating back. So that's what those tech. So we've had 3 major revisions of technical guidelines. There was one in 2002 that said we have 22 diseases. That's the one that, I mean, the WHO AFO started with and gave us. So we started using that 22 diseases, and then we revised it from 22 to 40 priority diseases in 2010. So I told you earlier on that it's no longer communicable disease focused the surveillance, but we're also looking at non-communicable diseases. And then we'll be able to add neglected tropical diseases. And then in 2018, we added event-based surveillance. So we're not just doing surveillance for a disease, we can have surveillance for an event. We can have surveillance for example, a disaster. We can have surveillance for an explosion. We can have surveillance for an environmental pollution. So there are different types of applications that you can have for surveillance. So let's look at the integrated disease surveillance and response, the current one that we're using, the current guidelines. Let's look at the objectives and strategies. So the goal of IDSR is to improve the ability of all levels of healthcare to detect and respond to diseases and conditions that cause high level of death, illness, and disability in the district or in the area. So the word district is the other name for it is local government area. So actually, disease surveillance and response is actually domiciled for interventions at local government area level. In fact, up to ward level and community level. So we want to be able to improve the ability of all levels of healthcare to respond, to detect and respond to diseases and conditions that cause high level of death. So IDSR is not focused on all diseases that ever occur, but on a specific set of diseases, the ones that cause high level of death, illness, and disability. What is the objective of the integrated disease surveillance and response currently in use? Remember the challenges that we had discussed a couple of slides earlier that are affecting surveillance. And so we would looking at how do we show up, how do we prevent, how do we respond to some of those challenges. So IDSR objectives are to strengthen the involvement of clinicians in disease surveillance, to build the capacity of staff to be effective in surveillance and response activities, to integrate different surveillance programs so that forms, personnel, and resources can be used effectively. We don't want a situation where a particular officer is running helter-skelter, reporting on 5 or 6 different things with different reporting forms and tools, and it becomes so stressful. Let's integrate all these programs. Improve the use of information for decision making. So decisions about vaccinations, decisions about preventive services should be made based on surveillance information. How do we strengthen laboratory capacity? That's one of the objectives. Remember, it was a challenge. It is a challenge. So strengthening laboratory capacity and its involvement in the confirmation of diseases. And then strengthening community participation in disease detection and response. So it's not just left to health workers alone. How do we make sure that members of the community are also able to support the surveillance response system? All right, let's look at the functions of the integrated disease surveillance and response. Identify cases, record cases, report cases, analyze and interpret data, investigate and confirm suspected cases, investigate outbreaks, respond, provide feedback, evaluate and improve on the system. So basically it is surveillance and response. So the first 4 that you will see is the first 5. 1, 2, 3, 4. Identify, record, report, analyze are surveillance activities. Then the rest are response activities: investigate, respond, provide feedback. And of course, there's a cross-cutting one: evaluate and improve on the system. So you carry out surveillance, you get information, you use that to respond. And then you feed back into the system to say, okay, let's improve our surveillance in XYZ manner. The supportive functions for surveillance are communication, training, supportive supervision, resource management, and mobilization. These are cross-cutting because these functions help. These functions actually help you to be able to achieve the functions of identification, recording, reporting, analyzing, investigating, and responding. So these ones actually help to make sure that, okay, you have the communication that you need to send your notification to a particular place. You have the capacity, the training that you need. There's a system where people are providing you with the support to be able to do the work. And of course, all these resources are available and mobilized to be able to, for you to be able to do your disease surveillance and notification. All right. So what are the diseases that should be reported? What are the diseases that we currently have in our disease surveillance and response system? We call them IDSR priority diseases. So what are the current IDSR priorities? And you remember, this list can change from time to time. This is not a list that is cast in and will never change. The list has actually metamorphosed between 2002, 2008, 2010, 2018, and so on and so forth. So in the IDSR technical guidelines of 2010, you see categories, 4 categories of diseases. 4 categories of diseases. You have 1, the epidemic prone diseases. Epidemic prone, of course, because they can cause outbreak. They can cause outbreaks. So they are, you know that, okay, they can start as endemic, but they have the potential to cause, to become outbreaks and to become epidemic. So you want to keep an eye on them. For these diseases, there's a threshold of number of cases that you should see, and that you start saying, we are an outbreak is upon us, or an epidemic is upon us. The second category are the diseases targeted for eradication or elimination. So there are certain diseases that we say we want to get rid of completely and totally. The same way we've gotten rid of smallpox, we want to get rid of these diseases. Polio is very high on this list. And I mean, those of you who are aware know the efforts that have gone into polio eradication across the world, and the fact that a few countries are still standing in the way of polio eradication, Afghanistan, until very recently, Nigeria, and so on and so forth. The third category is other major diseases or events or conditions of public health importance. So this is where you have a lot of the non-communicable diseases. Maternal death is not a disease, but it's an event. And that event is under surveillance. Hypertension, diabetes mellitus, adverse events following immunization, tuberculosis, malaria, and co are the kind of diseases that they are major. They cause morbidity and mortality, and want to keep them under watchful scrutiny. And then the fourth category are disease or events of international concern. This is where COVID comes in. This is where monkeypox comes in. This is where Ebola comes in. So diseases that are likely to take on national or international that are likely to become pandemics, that are likely to have an international, response. We also want to put them under those categories. So it would be good for you to know a couple of examples under each of those categories of diseases as we had them in 2010. All right. So this is WHO's list. This is WHO's list. Nigeria domesticated it. And instead of saying 4 categories, we say we were interested in 3. We kept the epidemic prone, we kept the disease targeted for eradication, and then we just said one more, other major diseases or events of public health importance. And so that's a measure of 3, category C and category D, that we have brought into this other major diseases, events, or conditions of public health importance. And of course, okay, yes, there you have here now. You still have the 4th category at the bottom here. Sorry, I almost missed it. Diseases or events of international concern. So it's the same thing as the WHO list. It's just that we've added a couple of things that are specific to us in Nigeria into this list. So you can go and look at the 2 lists and see what is in our list that is not in the WHO's list, and that may help you. All right. So how do you identify these priority diseases? Remember, I think I'd spoken to you earlier, a couple of lectures back, about case definition. And that's a standard description of a disease or criteria used to describe if a person has a particular disease. And it's standard. It's everybody can use it, and it helps you with a uniform way of identifying a disease. So priority diseases are identified using case definition. And remember, there are different kinds of case definition. There is a case definition for suspected case. There's another type of definition for probable cases. And then there's another one for confirmed cases. All right, so we've been talking about watchful scrutiny. We've been talking about reporting and notification. What do we report? So we looked at what we report. Now we're looking at how we report and who we report to. All right, this is very important. So the tools for recording, where we get information that feeds into the integrated disease surveillance and response system, is from outpatient department cards. We get it from clinic and health facility registers, and from case folders or case notes. All right. These are the tools where you can actually come and get information about any disease that you're interested in that has been seen, assessed by a healthcare professional, healthcare practitioner, and recorded. So once it is in any of these, you can extract from these tools and put into your report forms. So you have notification forms. There are 3 major tools for reporting. So you have tools for recording and tools for reporting. 3 major tools for reporting. We call them IDSR forms. So you have the form 001, you have the form 002, and you have the form 003. And in the form 001, you have 001A, 001B, and 001C. So let's look at it. Form 001, IDSR 001, A, B, and C is for outbreak reporting. So that's why it was made 001, because, I mean, this is emergency reporting. It's for outbreak reporting. 001 forms, A, B, and C are for outbreak reporting. What type of form is A, B, and C? So A is for collecting data on each new case of a disease that is suspected to be a disease that can be an outbreak or epidemic or pandemic. From 001, individual single cases. So for example, if from 001 will be used to collect information from a suspected case of Lassa fever, or from a suspected case of monkeypox, or a suspected case of measles. One case, we will fill the information about that particular person who has that disease and the kind of disease the person has in that form. Form B is a lab form. 001B is the form you use to collect the sample and send to the lab, and that is where the lab puts in the results. So for Form 001, it is suspected or probable cases that you record, each individual suspected or probable case that you record. Form 002 is for confirmation. It's for confirmation of each individual suspected case. So if you want to move from suspected case to confirmed case, you need a lab form 001B. You fill the information, send to the lab will do the test, provide you with results, and all that is in form 001B. Now, 001C is what we call a line list. We call that a line list. This line list form now is not just only for a single patient. You can use it for a single patient, but you can now use it for many different people that have that particular disease. And so it provides you with basic information, some social demographic details, including, and then of course you go on to talk about what are the prevalent signs and symptoms, what are the lab results, and all you follow that up until you talk about the outcome. Did the person die? Did the person survive? Was the person cured, healed? Did the person have any disability as a result of the disease? So you use that. So this line list is almost like how an Excel spreadsheet would be, and you have different columns that collect different information. So for when you're investigating an outbreak, for example, you would use each person that you are suspecting to have a disease will get a form 001A. If you are sending the information, the sample to the lab for diagnosis, that same person will get a form 001B. But if, for example, there are 25 people in that community that you are suspecting may be infected by a particular disease, and you've given each of them 001A and 001B, plus or minus 001B, you will now put all their information in an 001C, in like a tabular format. I hope that makes sense. Now, from 002, IDSR form 002 is for weekly reporting. Either suspected cases or laboratory confirmed cases. And this is routine reporting, and it happens at the health facility. So every week, the health facility is supposed to come together. It's supposed to put together the information, capturing the information of all the diseases on the priority list according to the technical guidelines. whether they are suspected or laboratory confirmed. They put them in that form 002, write it out, fill it out for the facility. So the number of cases of this, that. Not individual names and the characteristics of their disease, but this one now is now an aggregate. So this week we saw 5 suspected cases of measles. There's somewhere to record it. We saw 1 suspected case of chickenpox. We saw blah, blah, like that, and they just record it. HIV 1, 5, like that. You just record and send. Then you have 003. You have 003. So it's for capturing data on a monthly basis. So 002 is weekly, 003 is a monthly form, and 003 is what is actually submitted. 022 is submitted. All of them are submitted, but how they are submitted and when they are submitted is what we will look at in a couple of slides down the road. All right. So these forms, hard copy, these forms are actual hard copy forms, even though there's electronic versions of these forms now. And the electronic versions exist, but they are also initially there as hard copies. So assuming that we're still talking about hard copies, you send the form forward to the next reporting line where you keep a copy. You keep a copy with you and you send your original. So those forms actually come in duplicate or triplicate copies, where as you're writing, it is like there's carbon paper there and it's filling into the other copies. All right. So there's weekly transmission and there's monthly transmission. And then there's also on-the-spot transmission, depending on what you're dealing with. If it's an 001 form that you're filling, you notify immediately. If it is 002, then it's at the end of the beginning of the new week. Once the old week has ended, at the beginning of the new week, by a particular deadline, we'll see that in a couple of slides, you should have sent that form. And if it is monthly reporting 003, there's a particular deadline in the new month where you should have sent it. It's very important to know that even if there's no case of a particular disease that you're interested in, one of the priority diseases, 0, you should write 0 in the form and send, because 0 reporting is reporting when there's no case, and it's good information. For the past 1 month, for the past 6 months, there's been no case of this particular disease. So the day you now report and you see 1 case, everybody's antenna is up. Why did it go from 0 to 1? It's not the same thing as not. Oh, there's no case, so I didn't bother sending in the report. That could mean a lot of things. It could mean that you are there, you are seeing cases you are not reporting. It could mean that you do not have the logistics of the training to be able to report. So it's better you report and say 0 cases. All right. This slide shows the flow. This slide shows the flow of the reporting. I'd like us to just look at it very carefully. So you start from the top and you go down. All right. So in the pink here, you're seeing health facility, IDSR 002. IDSR 002 is a weekly reporting. All right, it's a weekly reporting. And it goes, the reports for the Monday and Sunday should reach the LGA by the Monday of the following week. So there is an LGA, disease surveillance and notification officer. The health facility sometimes will have a surveillance officer, but again, it might just be any health worker in the health facility whose responsibility is to fill out this form. And then the form must be sent by the Monday of the next week, so covering the week before. And it's sent to the local government. And then the forms from the local government are supposed to reach the state by the next day, that's Tuesday. So if if health facility submits to LGA on Monday, by Tuesday, LGA is supposed to submit to state, collate from all the health facilities and submit to state. And then from the state, it's supposed to go to the national by Wednesday. So Monday, LGA, Tuesday, state, Wednesday, federal. That's how it goes. That's how it goes. And
if you see that you have arrows going from health facility to LGA to state to national, but you also have arrows going from national back to state, back to LGA, back to health facilities. So because reporting goes down, feedback should come back. And so feedback should come back between 3 to 7 days after receiving the report. Or if there's something that is urgent, if the report has in it maybe a disease of epidemic, a novel disease, an emerging or re-emerging disease, the response should be immediate. Sometimes you have bulletins and publications. So what happens, for example, for CDC now, if you go look at it, CDC now has weekly reporting for a lot of the diseases that are of epidemic potential in the country. So that's their own way. They've aggregated, they've collated, they've analyzed, they've done some interpretation, and they publish it. We can all go there and see what's happening. All right, so this is for Form 003. It's the same transmission protocol from the health facility to the LGA, from the LGA to the state, from the state to the federal government, Federal Ministry of Health. But notice that this is a monthly report, and so 1 week after the end of the month, the report should be sent. 1 week from the health facility to the LGA. 2 weeks after the report has been generated, 2 weeks after into the new month, it should be sent from the LGA to the state. And 3 weeks after, by 3 weeks after, latest, should be sent from the state to the national. And of course, feedback should come within 1 or 2 weeks after a receipt of the report, except there is an urgent situation. And so feedback should come earlier. All right. Now, there are some very important indicators. So indicators actually tell us whether we are doing well with regards to the objectives of a particular program or project. So indicators tell us how far have we come, how are we going to measure what is happening with this project or program. So some of these very important indicators, I'll just take a few of them for you to see. So reporting, the first one is we want to know, we're monitoring the proportion of health facilities that submit reports. So are they reporting at all? Are they reporting in a timely manner for the different kinds of diseases? These are some of our indicators. So we have indicators for also analysis. Are we analyzing properly? We have indicators for laboratory support. What was the proportion of cases that had a laboratory confirmation? We have indicator for response. What's the proportion of the confirmed cases that had a proper and adequate response? Of course, we have indicators for things like case fatality, which is the number of deaths that occurred in the cases identified. And then attack rates, what are number of cases that you're getting compared to the entire population. All right. So the next couple of slides is just to say, look, what is our role? What are we supposed to do? Let's look at health facilities, tertiary, secondary, primary health facilities. Timely reporting is very important to ensure that the health facility staff have the training for IDSR. You have the trainings. Laboratory diagnosis is available, and effective case management is also available using standard guidelines. The role of the health facility is also to make sure that there is a technical and logistic support for epidemic response if necessary. Then, of course, provide, services, provision of services, interventions like immunization and so on and so forth. Of course, public and private health facilities also have the same responsibility to respond to immunization services, to support data generation. One of the challenges that we see is that while there's a very solid system in place in the public health facilities for reporting, you don't have that same picture in the private health facilities. You find it very difficult, very, very, very difficult to report. Okay, so that is that about the surveillance and then the integrated disease surveillance and response system. I'll be happy to take your questions and contributions now, please. Thank you.